Hi, my name is Luisa Dasgale and I am the leader of the Group 7, also known as Germ Cities, and we will be presenting you a urogenital infection. So before we proceed to our presentation, we would like to introduce ourselves. So me first, I am Luisa Dasgale and I am the leader of the group.
Hi, I'm Carl Kevin Obusurdita.
Hello, I'm Julia Angela Odonoso.
Hi, I am Erica Marie Magnaya Fernandez.
And I'm Ulysses Sile S. Ibarra.
So, we would like to start our presentation by reading to you our case study, and it will be read by Julia.
So AC, a 29-year-old woman presents for the evaluation of pelvic pain. The pain has progressively worsened over the past week. She has also been having some burning sensation with urination and a yellowish with a strong odor vaginal discharge. She is sexually active, has had 10 sexual partners for the past 2 months, took oral contraceptive pills, and occasionally used condoms. On her examination, she appears in no acute distress and does not have a fever. Her abdomen is soft with a moderate lower abdominal tenderness. On her pelvic examination, she is noted to have a yellow cervical discharge and significant cervical motion tenderness. No uterine or adnexal masses are palpated, but mild tenderness is also noted. A gram stain of the cervical discharge reveals multiple polymorphonuclear leukocytes, few gram-positive rods, and foci in pairs, and occasional gram-negative rods. A chlamydia rapid antigen test on cervical discharges subsequently comes back positive. Next, please. So here's the image of cervical discharge gram stain smear under the microscope, and this pertinent lab in chlamydia rapid antigen. So the next presenter of this slide is Miss Luisa Dalzor Gohilde.
So hi, I'm here again and I will be presenting you the important details of the study. So first is the patient's general profile. It is mentioned that our patient is a 29-year-old woman and also named AC. The religion of the patient and also the date of admission is also not disclosed. As for the objectivity and subjective information of the patient, she came to our hospital because of the chief complaint, pelvic pain, and also the other symptoms, burning sensation with urination, and yellowish with a strong odor vaginal discharge. So the history of the present illness is that 1 week prior to admission, there is already presence of pelvic pain, burning sensation with urination, and also the yellowish with a strong odor vaginal discharge, which has also worsened over the week. As for the patient's past medical history is not disclosed, and also for the patient's family history is undisclosed. For the patient's social and drug history, it is mentioned that AC is sexually active. She had 10 persons or partners within the past 2 months. She also took oral contraceptives and also occasionally used condoms. As for the patient's comorbidities, it is undisclosed. So for the next presenter, it will be Julia Angela Donoso.
So the physical examination of patient, there's no acute distress, no fever, but has soft abdomen and moderate lower abdominal tenderness. And so as to her pelvic examination, there is yellow cervical discharge, significant cervical motion tenderness, and uterine or mild adnexal, but no uterine or adnexal masses. Next. So in gram stain, it shows multiple polymorphonuclear leukocytes and has few gram-positive rods and foci in pair, and also in occasional gram-negative rods. And as to her chlamydia rapid antigen test, and they used the patient's specimen cervical discharge. So next slide. So in this slide, the next presenter will be Ulysses Kyle Ibarra.
So for differential diagnosis, we have here four, which is UTI, pelvic inflammation disease or PID, cervicitis, and adnexal tenderness. For UTI, this type of infection can involve your urethra, kidneys, and bladder. For pelvic inflammation disease, it is an infection of one or more of the upper reproductive organs, including the uterus, fallopian tubes, and ovaries. For cervicitis, it is an inflammation of the cervix and often does not cause symptoms, but if they do, they may include abnormal vaginal discharge. Four would be the adnexal tenderness. Adnexal tenderness is a technical term for pain in the area of the woman's uterus. Trivia: adnexa is a Latin word meaning attachment or appendage. It refers to the ovaries, fallopian tubes, and ligaments that hold reproductive organs in place. Next slide, please. So we have here different tables about history of pelvic pain, its differential diagnosis, physical examination, pelvic examination, and we also tackled here the three differential diagnoses again and to consider our final diagnosis. So let's tackle first for history. For history, we have your present illness of symptoms. We have your pelvic pain. Other symptoms: burning sensation with urination, yellowish with a strong odor vaginal discharge. And for patient or drug history, we have here sexually active 10 persons within 2 months. For differential diagnosis, we have here four. Like I have stated a while ago, we have here UTI, PID, cervicitis, and adnexal tenderness. For physical examination, we have here acute distress, that is positive, fever, is negative, soft, moderate, lower abdomen tenderness is positive. For pelvic examination, we have here yellow cervical discharge, which is positive, significant cervical motion tenderness, which is positive, uterine or adnexal mass is negative, and uterine adnexal mild tenderness positive. So there were three differential diagnoses. Those were cervicitis, adnexal tenderness, and UTI. So consider that the final diagnosis, we consider it pelvic inflammation disease, but because it has soft, moderate, lower abdomen tenderness, pelvic pain, burning sensation with urination, and yellow discharge. So the final diagnosis would be pelvic inflammation disease because stated a while ago, it has soft, moderate, lower abdomen tenderness, pelvic pain, burning sensation with urination, and yellow discharge. So the organism. So for gram-negative bacteria rods causing PID, we have here Chlamydia trachomatis, Neisseria gonorrhoeae, and Mycoplasma hominis. Chlamydia trachomatis is most commonly spread through vaginal, oral, and anal sex, in short, STD. For Neisseria gonorrhoeae is a bacteria responsible for gonorrhea and various sequelae that turns and occur in asymptomatic infection ascent. Mycoplasma hominis is a common molecule bacteria present in almost every human in their urinary tract. So what is molecule bacteria? Molecule bacteria is a class of bacteria distinguished by absence of cell wall. So gram stain, we have here two, Chlamydia trachomatis and Neisseria gonorrhoeae. For the chlamydia rapid test, it shows here that it is positive, and our organism here is Chlamydia trachomatis. Next.
Next slide.
Next slide. Yung presenter dito.
So the next presenter on this slide will be Erica Fernandez.
So for the taxonomy of Chlamydia trachomatis is the domain bacteria, the phylum is Chlamydiae or Verochromicrobia group. For the class is Chlamydiae, the order Chlamydiales, family Chlamyd Chlamydiaceae, the genus is Chlamydia or Chlamydophila. For the species is Chlamydia trachomatis, Chlamydia moridarum, Chlamydophila pneumonia, Chlamydophila psittaci, Chlamydophila abortus, Chlamydophila caviae. For the characteristics of Chlamydia trachomatis is inclusion morphology. It is round and vacuolar. For glycogen in inclusions, it is yes. Elementary body morphology, it is round. Susceptible to sulfonamides, yes. Plasmid, yes. Serovars, 15. Natural host, humans, and mode of transmission, person to person or mother to infant. The major diseases is trachoma, STD, infant pneumonia, lymphogranuloma, venero. For the virulence factor, adhescence, MOMP, major outer membrane protein, and heparin sulfate like proteoglycans. Invades specific types of host, epithelial cells, mucosal epithelial cells, primary target cells type in vivo. Lipopolysaccharide, nutrient uptake, oligopeptide, permease transporter system, intracellular organism, and type 3 secretion system. That's for the virulence factor. The next presenter is Carl Kevin.
So the biochemical tests applied in the lab are chlamydia rapid test and the gram stain. Next slide, please. Types. Chlamydia trachomatis has been divided into two biovars, trachoma and lymphogranuloma venereum. In addition, characterization of the MOMP has separated Chlamydia trachomatis into 20 serovariants or serovars. The trachoma biovar includes serovars A through K. Serovars A, B, A, and C are associated with the severe eye infection trachoma, whereas serovars D through K, DA, IA, and GA are associated with inclusion conjunctivitis, a milder eye infection, and urogenital infections such as urethritis, cervicitis, pelvic inflammatory disease, and epididymitis. Serovars L1, L2, L2A, L2B, and L3 are associated with lymphogranuloma venereum, an invasive urogenital tract disease. Next slide, please. Diseases. Chlamydia trachomatis has been known to cause non-gonococcal urethritis, an infection of the urethra caused by an agent other than Neisseria gonorrhea. In males, it includes epididymitis, inflammation of the epididymis, prostatitis, infection or inflammation and pain in the prostate gland, orchitis, swelling and pain in one or both testicles. For females, it also includes cervicitis, inflammation of the cervix, PID, infection of a woman's reproductive organs, endometritis, and inflammation or irritation of the lining of the uterus or endometrium, salpingitis, inflammation of the fallopian tubes, tubal factor infertility. It is when a blockage in the fallopian tubes will not allow the egg and sperm to meet. An ectopic pregnancy, when a fertilized egg implants itself outside of the womb, usually in one of the fallopian tubes. Next slide, please. Lymphogranuloma venereum, or LGV. Chlamydia trachomatis serovars L1, L2, L2A, L2B, and L3, which are more invasive than the others, cause LGV. a sexually transmitted disease. Patients with LGV present with inguinal and anorectal symptoms. Trachoma. Chlamydia trachomatis causes the chronic eye infection trachoma, the number one cause of preventable blindness in the world. Trachoma is associated with serovariants A, B, BA, and C. Oculogenital infection, conjunctivitis. It is an inflammation of the conjunctiva that usually presents as acute follicular conjunctivitis. Chlamydial infection in the newborn. Newborns can be infected with chlamydia trachomatis while traveling through an infected birth canal. Newborns with chlamydial infection can experience conjunctivitis, nasopharyngeal infections, and pneumonia. So those are the diseases associated with chlamydia trachomatis infection.
So, for the prevention and tips.
Okay. So here in prevention and tips, first is use condom, of course. So condoms are the best way to prevent STIs when you have sex, because a man does not need to ejaculate or to give or get STIs. Make sure to put the condom on before the penis touches the vagina, mouth, or anus. Other methods of birth control, like birth control pills, shots, implants, or diagrams, will not protect you from STIs. So the second here is get tested. Uh, be sure, be sure you and your partner are tested for STI. Talk to each other about the test results before you have sex. So the third one would be monogamous. Having sex with just one partner can lower your risk for STIs. After being tested for STIs, be faithful to each other. That means that you have sex only with each other and no one else. Next slide. So, limit your number of sex partners. Your risk of getting STIs goes up with the number of partners you have. Do not douche. Douching removes some of the normal bacteria in the vagina that protect you from infection. Douching may also raise your risk for PID by helping bacteria travel to other areas, like your uterus, ovaries, and fallopian tubes. And lastly, do not abuse alcohol or drugs. Drinking too much of alcohol or using drugs increases risky behavior and may put you at risk of sexual assault and possible exposure to STIs. So that's all. Thank you very much, sir, and all of you. Bye.